audio. My name's Elizabeth Burrows with Burrows Consulting, and today is an exciting day for us. Thanks to the Flex program, funding from Joyce Fillenworth with the State Office of Rural Health, and Nerea also has helped with this program. So this has been something a long time coming. We do an annual summer rural health clinic update webinar. Please note that we will be recording this, each individual speaker. So that way, if people were not able to be on, we would have that recording available for them. This is a special program put on for Indiana Rural Health Clinics, and we always have amazing attendance. We're going to try to keep everyone muted, but feel free to unmute if you have questions or comments that you want to share. We all learn from each other, and that is great. Again, as always, if you have questions, you're welcome to email Callie, Melissa, or I. We will put that into the chat, our email, so you can email any questions for the speakers or any additional details that you need. And then there should be time at the end of each individual presentation to ask questions. You can also put those in the chat. Callie will be monitoring the chat and asking questions accordingly. Again, we're really thankful to have a great turnout from the Indiana Rural Health Clinics. We know you're doing amazing work, and please know that we are a resource for you, especially if you're working on behavioral health integration. Melissa and I are here also working with Z codes. We are here, and that is paid for through the State Office of Rural Health. So we are here as a resource to reach out if you have any technical assistance needs. Again, thank you for joining us on this back to school week. We're excited not only to have our students learning, but have all our rural health clinics learning again. And it's an honor to work with each of you. I know some of you I hear from more than others. I hear from Amy quite regularly, and I always hear the great work that's happening in Decatur, and I know you guys are moving and shaking. I also know Brad up north is doing awesome things, so I'm excited to hear all the new things that he's doing. Again, as you guys know, Melissa or I might be calling you out if we don't have any questions come through. So make.
Oh, I think we might have lost her. Yeah, I think it's. So we lost Elizabeth, but I would second what Elizabeth is saying. Again, everybody, thank you for joining and being a part of our RHC Lunch and Learn session today. We're honored to host this event. Of course, we are very honored for this. We will be joined today by our excerpts from Quad A, the HSA Group, and North American Healthcare Management Services. We're going to be discussing compliance, the chart auditing process, and updates and changes to behavioral health. I am honored to now welcome our speakers from Quad A, Michonne Mayfield and Elsie Crawford. Michonne is the Director of Business Development at Quad A. She has been in the healthcare accreditation industry for over 25 years. She specializes in healthcare accreditation with a wide array of experience in training, development, and accreditation management in various healthcare settings. Michonne has experience with the Medicare Deemed Status Program for providers and suppliers is just as extensive. She and the accreditation team at Quad A are always available and happy to aid outpatient healthcare settings as they begin or renew their accreditation. I know that Michonne will call on Elsie, but I would like to give Elsie a little introduction here as well. She is the Vice President of Operations and Director of Nursing with Wilkins Medical Group in Jellicoe, Tennessee, and manages clinics in Kentucky and Tennessee. Elsie attended Cumberland College and Carson Newman College for Business, sorry about that, Administration, and Rowan State Community College for Nursing. She has been the Vice President of Operations and Director of Nursing for Wilkins Medical Group in Jellicoe, Tennessee since 1974. She is certified medical rural health clinic surveyor and works with Quad A doing clinic surveys. Elsie has served on the board of the Tennessee College of Applied Science since 2004, my apologies, and a board member of NARC from 2006 to 2019. Jellicoe SDA Church School Board member, treasurer for 9 years, and Jellicoe City Council member for 12 years, and Quad A board member for 4 years. I am thrilled to welcome Michon and Elsie. Please take the floor, ladies.
Well, thank you very much, Melissa, and I am so pleased to be here. And I welcome you all, neighbor state. I'm in Illinois, more to the north near Wisconsin, but certainly very happy to join you today. So if you bear with me just one moment, I'm going to go ahead and share my screen. Oh, I need the host to allow me to share my screen, please. As we play Jeopardy music in the background. And I would be ready to go, and I will call upon Elsie in various spots. She is one of our valued surveyors, and I'm so excited that she'll be helping me out today.
You should be able to share now.
Okay, fantastic. Thank you. Okay. All right. Is everybody able to see my screen? Okay. Everybody can see my screen?
You're good.
That's good.
Okay, fantastic. Okay, well, today I'm going to talk to you about the foundations of compliance. And again, I'm being joined by Elsie Crawford, who is our nurse surveyor, and I am the director of business development. And if you don't mind, I'm going to move myself out of the way so you can focus on the slide. All right. Well, the learning objectives today are really to help you understand how compliance is assessed by a surveyor and what to expect during a survey, as well as the types of deficiencies that may result in non-compliance when identified. Also to communicate, we're going to provide you with information about our top 10 deficiencies and operational processes that you can implement to achieve ongoing compliance and always stay patient and survey ready. Our compliance, our surveyors are fact finders, and they are there to evaluate the compliance of the facility against Medicare requirements. They conduct unbiased assessments, and they are trained, obviously, to apply the standards consistently and also to make clear citations in their findings. They address the corrective actions that are required and identify best practices beyond the citation. Now, please understand that our surveyors are actually peer surveyors, such as Elsie, who has been in the rural health industry she has quite that expansive experience. And the great thing about our requirements is you either meet the requirements or you don't. There's compliance and non-compliance. And one of the expectations is evidence of corrections should there be any identified deficiencies. Now, what to expect during a survey? The surveyors are there to collect information, and they will interact with staff and patients. They are primarily collecting information through observation and also staff interviews, and by also conducting review of policies and procedures related to patient care. Now, the surveyors will provide, will ask open-ended questions because they really do want to understand the how and why of what the staff and how they carry out their duties. The surveyors may also request a demonstration. Surveyors may offer suggestions that don't necessarily indicate that there is a deficiency. This is part of the best practices that they may be able to provide some information on. These are suggested practices, and it provides other ways that may be available to achieve compliance. And ultimately, the medical director is responsible to determine how to correct deficiencies. Surveyors throughout the survey process will ask for records of various components of the accreditation of the Medicare requirements, such as emergency drills and their results, the evaluation, and so forth, the policy, the plan, and the written quality improvement program. And Also, just to let you know that there is no need to print off any documents. This is really the surveyor's responsibility to evaluate the organization's compliance based on how the information is provided to them. So it could be electronically, it could be in paper. Now, one of the things that's key as part of the survey is obviously the end of the survey, and that is where the surveyor will provide very detailed information with regard to their findings. Now, one of the things that I will tell you is that the surveyor throughout the survey day has been communicating with various folks, so there should be no surprises as far as any of the findings. But one of the things that would be the culmination of the survey day is the summation conference. And what's expected is, or as the organization outlines, who is going to attend this conference. Typically, it's clinical leadership and critical staff. It is the surveyor's responsibility to discuss all the findings, including each citation. They are there to really discuss and make sure to fully, for the organization to fully understand what the findings are. This is what I discussed as far as someone is always in communication with the surveyor. They are there to provide educational information, also suggestive corrective practices if possible. They again and are not able to consult and provide consultation, but there may be some best practices they can impart. They are there to collect the facts only. That is what their role is to document the facts as they observed. They may include some helpful tips, and ultimately the findings get reported to our accreditation committee, who make the ultimate accreditation decision. Now let's discuss the type of deficiencies that might be identified as part of a survey. For Medicare purposes, there's standard level deficiencies. These are standards that with non-compliance, it may be a portion of the conditions for certification that have been identified as out of compliance. Now, with this type of finding, I thought I heard somebody. With this type of finding, the clinic can remain accredited and Medicare certified, but they must embark upon a plan of correction process that's very prescribed, and how the facility will achieve and ultimately sustain compliance over time with the non-compliant standard. The next kind of deficiency, and is a little bit more severe, is more crucial, is the condition level deficiencies. Now, the condition level deficiencies means that the surveyor has identified significant non-compliance with possibly an entire condition for certification or several standards within that condition that represent a serious threat to patients' health and safety. So with that kind of a finding, this accreditation, especially for a renewal, it requires that there's an on-site assessment of the correction that the facility has implemented, and requires the organization to reevaluate those deficiencies that were cited during the survey, and also for facilities to make sure that they are prepared for a follow-up survey by Quad A because of the level of severity of the deficiency. For those facilities seeking initial accreditation for Medicare certification, a condition level deficiency could result in non-recommendation for Medicare certification, and the facility would have to go through an initial survey once again. So this is quite severe, and it is imperative that the organization is prepared for their survey so that they avoid this level of deficiency. Now, immediate jeopardy is the most severe type of deficiency that can be identified. And this is truly when this is the highest level of deficiency, and this is applied when it is a non-compliance has been identified that may cause or is likely to cause significant injury, harm, or death to a patient. The accreditation outcome, the provider agreement would be terminated if the immediate jeopardy is not abated. Quad A will conduct a follow-up assessment to determine that all the conditions have come into, all the conditions are in compliance, and no longer is there a threat to patients' health or safety, and the potential for causing any further harm. So again, this is one of those areas that is very significant, and the organization should do all it can to ensure that it does not find itself in a position of immediate jeopardy, because again, that provider agreement could be terminated, or the facility would not be recommended for initial certification. Now, this is the opportunity for me to work with Elsie here. Elsie is one of our surveyors for rural health. And these are our top identified deficiencies. And what I'd like to do is have the opportunity for her to, if you could come off mute, Elsie, is to really provide some insight into some of the things that she's seeing out in the field with regard to some of these deficiencies. So for our first deficiency that's fairly prevalent, it is for patients receiving healthcare services. By maintaining a record, the organization maintains a record that includes identification and social data, as well as evidence of consent forms, pertinent medical history, assessment of health status, and the healthcare needs of the patient, and a brief summary of the episode, disposition, and instructions to the patient. So I know I should have allowed you to read that, but if Elsie, would you have, are you off mute so that you could let us know what are some of the things that you're experiencing when you identify this standard is out of compliance?
Can you hear me? I am off mute.
And
Can you hear?
I can hear you just fine.
Okay, all right. As a surveyor, when I go into clinic after clinic after clinic, there seems to be certain deficiencies that become the top 10 deficiencies. And what you're looking at today is 2023. It's quite the deficiencies that we found to be the most prevalent. And when you look at standard 491.10, or when this is the chart, these are records that are contained within the medical record or chart of the patient. And what I find most, and my friend or peer surveyors say to me that they find this also, is the consent form. Consent to treat seems to be one that just they have a problem obtaining. But that, when I go in to educate. I do not go in to punish. I think my reputation will bear that out. But consent forms, you come up with the method that is best for your practice, and that's how you obtain any record that you do. Some clinics have the consent form signed every time the patient comes in, and they say this really helps because the front person does not have to go back, check a date, and make sure. If their policy says it's yearly, they make sure that it's been signed within the proper time. Some don't do that. They get it signed every 6 months. Some get them signed every year. Whatever you choose to do, is vital that you look at the standard, see what's necessary to be contained within your record, and make sure that that is there, because this is a biggie. It just seems to be so prevalent out there about the consent forms. And that's what I've found on that particular standard, the deficiency for that standard. Michonne, do you want me to go on with each of these deficiencies?
You know what? That would be fantastic. That allows folks to read the deficiencies and you to expound on them. Thank you.
Okay, and we look at standard 491.6, and this is a very important one also. The clinic keeps the drugs and biologicals appropriately stored. Now, this means that you look at what Medicare's standard says that you have to do, and you've got medication has to be behind locked doors. You can't have it out where it's unlocked. You have to make sure if you have sample medications that you're keeping a log on those. You know that they're in date. You know who gets those medications. In case that you get a recall on a medication, you'll be able to immediately tell which of your patients are on that particular medication. But you just make sure that you follow safe practices with your drugs and your biologicals. Don't store certain injectables that look the containers may look very similar. Don't store those side by side. Do whatever you need to do. And remember, this is your clinic. This is your clinic to make the call, not mine as a surveyor. I can explain the standard, but you're the one that decides how you're going to follow that standard. We go in, the third one, this preventive maintenance or standard 491.6B, that is one that I also find seems to cause a little problem for the clinics. But you must have in place a maintenance program that ensures that all of your equipment, all of your electrical equipment and other equipment that you utilize in patient care, that's checked per your policy. Now, you're going to have a policy saying that you have a preventive maintenance program in place and that your equipment is checked annually. And if that's it, make sure I like the stickers, because if you have stickers on those, I could go by that. If you don't have stickers, then we got to pull that log. Every single piece of equipment you've got has to be listed. And we have to go back and look at the date on that to make sure that it was checked in a proper and at a good time and according to your policy. So it's best if you've got some method to be able just to look at that piece of equipment and see that it was checked. When we look at standard 491.9C, we see that it says the clinic staff has to furnish diagnostic and therapeutic services and supplies that are commonly furnished at the entry point in a physician's office. Well, we all know what that is. We look at it we want to make sure that there's a medical history, there's a physical examination, that you've assessed the health status, all of the things that fall within the line of good practice. This is another record that's in the chart also. So make sure that when you have devised I call it a blueprint for your charting, because with electronic medical records, it's real hard to make a mistake unless you just, you almost have to try to, because those things are so structured that you pretty much are going to make sure that, or you are going to see that they're all carried out properly. But when you're deciding how you're going to do this, make sure you're including all of these things so that when we go in and do a chart audit, we can look at it and we can see that you are furnishing the tests and the services that Medicare says that you have to furnish with this particular standard. Also, 491.11, this kind of goes along also that the evaluation, you're going to do an evaluation to make sure that the services that you're providing are appropriate, that the utilization of this service was appropriate. This you're going to do when you do your program evaluation. So be sure that you have in place a policy that allows you to determine whether or not the services that you're rendering are appropriate. Okay, next page. Okay, thank you. We look at 491.17, and this, for some reason, is also a biggie. It is the clinic has clearly disclosed the name and address of the person principally responsible for directing the operation of the clinic. And now, if you will notice, it says disclosed. It does not say that you have to post it. It's good if you do, because most people just put all of this information and post it. But if you have it disclosed in some other method, and you can show me where it's disclosed, that somewhere, it could be in your policy manual, but you just have to make sure that it is very clear and you have it disclosed somewhere, the person who's responsible for seeing the day-to-day operations of your clinic. Now we go down, and really, I think this one should be the next one, 491.7B. That's when you disclose the name and address of your owners in accordance with Section 1124 of the Social Security Act. That kind of goes along with disclosing the person who sees the daily activities of your office. You got to do your owner, you have to disclose your owner, you have to disclose your medical director, and you have to disclose the person who's responsible for the day-to-day operation of your clinic. Make sure that you've done that. If you put all three of these together on one post-it and you post it, that's wonderful, because I walk through and go through the waiting room and look at all the signs. I also look at, to make sure there's safety covers on all electrical outlets. I do all this stuff while I'm waiting on you guys to get everything locked up in the back and, you know, get the office manager out to see me and let me in. So I just kind of do my clinic walkthrough in the waiting room while I'm waiting. So make sure that somewhere you've disclosed these, because that one does get a lot of deficiencies, and we do have to ding you over that. And I hate doing that so bad. And we look at 491.6B, and you keep your office or your premises clean and orderly. And I see this. This is not something that I say. I'm surprised that that's one of the major ones, or the top 10. We look at where you provide medical emergency procedures as a first response, and you have the drugs that are necessary to keep this patient going until you can get them transferred. Now, at one point in time, we had to make sure you had an analgesic, the antibiotics, the anticonvulsants. That is no longer the case. Your medical director and one of your mid-levels, or whoever you all choose to be on that committee, decide what you want, what is necessary in your clinic to maintain that patient until they can be transferred. And that's what you need to have in your emergency kit for on the site emergencies that happen. So make sure that you list those medications. If you've got a box of some sort that you use, make sure there's a list of those medications that's posted to the top of that. Make sure that in your training you also include what the emergency medications are. So remember that it's up to your medical director and whoever he or she chooses to determine what you need for your particular clinic. And here is another one, the last one that we will talk about is one I think, I can't say this for absolutely sure, but I believe you're going to see this go away the first of the year. And I will be so happy, because you do provide basic laboratory services. Don't have to do those tests, just have to have the equipment to be able to do those tests. And the one that seems to be missing the most is the hemoglobin or hematocrit. And I'm not sure why that is, but you know, the fact that if you don't have the equipment and you don't have the controls to be able to make sure that the quality controls are in place, you're going to get dinged, you're going to get a deficiency, even though you don't have to do the test. But I think about the first of the year, and under the Modernization Act, you're going to see this one go away, and I hope so. Okay, Mashawn, that's my little discussion of the deficiencies. Are there any questions?
I haven't seen any come in through the chat. If there is anybody that wants to unmute, there hasn't been a question inserted in the chat yet.
Okay, thank you.
Okay, thank you so much, Elsie. That was so fantastic. Thank you again. And we will move on. We will now talk about the strategies for sustained compliance. We hope that we can provide you with some of the the operational processes that will help you to achieve ongoing compliance and stay survey and patient ready. Now, staying survey ready is an organization-wide effort. I would say make accreditation readiness organization-wide. One of the things I would say all the time is accreditation is a team sport. Not one person can do it by themselves. Obviously, you achieve success as an organization. So it would be helpful that your organization really get buy-in and from staff and leadership, which is critical to the success of your organization. You want to make sure that you prepare for your survey, but always be survey ready. So you shouldn't be preparing every 3 years. You really should be preparing routinely. Whatever monitors that you have in place and those that we discuss further will hopefully help you stay ready. Now, using your resources, making sure that you're using your accreditation standards manual, the CMS guidelines, any checklists or worksheets that help you evaluate your records, and ensuring that you're staying in compliance with all your local and state requirements. That would be one of the things that maybe you assign to one person, that they monitor state requirements, because that can be a full-time job sometimes, just trying to maintain, trying to stay up to date with what's happening in the regulatory arena. But again, by staying in touch with the CMS guidelines, that will also help you. Having at your fingertips and available to all your staff the information with regard to Medicare requirements that that are relevant for your organization, as well as in the accreditation requirements, whether it be Quad A or the compliance team or Joint Commission. You want to have all of those requirements available so that your staff is familiar with the accreditation requirements and Medicare requirements, and they know where to locate them. It is also great practice to have the ability to conduct a self-survey. This is where you actually take your requirements, whether they be both Medicare and accreditation, and you go through and evaluate your compliance. What would be advantageous is if you break it up into smaller chunks and assign various folks to actually go through and determine if the requirement is met and how it's met, and in any identified deficiencies. It's a great exercise for the team to go through and determine what are the plans of correction to fix those areas, and how do you achieve ongoing compliance. It is imperative that you routinely review and update your compliance documents. The facility license, making sure if that's applicable to you, that you maintain that as required by that licensure body. Policies and procedures really should be reviewed on an annual basis and have current review, and also acknowledgement of understanding from staff, records demonstrating compliance, any record reviews that you have, evaluating your clinical records, your personnel records, which goes into our next point about self-audits. These are some of the things that you can do to continually monitor to make sure that you're meeting your time-based requirements. Having appropriate meeting minutes documented, and also ensuring that all biomedical and other inspections are conducted on their routine basis. Now, with regard to a physical environment, there's numerous expectations with those. And as you can see here, one of the things that we want to point out to you are examples of federal and state posters that must be placed where they are visible to all employees. One of the things I might challenge you with is, do you have the current year's posters on your walls for your staff? So I won't go through this exhaustive list, and but it is hopefully you'll get a copy of these slides. But these are some of the things that you want to have available for your staff. Now we'll talk about the compliance with federal, state, and local laws. The staff of the clinic really must be licensed, certified, or registered in accordance with applicable state and local laws. Making sure you have an annual review to ensure current licenses and certification as part of your normal operating process would be advantageous, and again would ensure that you don't have any staff that are out of compliance with licensure and certification rules that are applicable to them. What your personnel files should contain are listed here. This is some of the things that the surveyors obviously will be looking for. It would be advantageous for you to create a checklist of items that should be located in your personnel files, and ensuring maybe having a checklist on each file, making sure that each of those items are there. These are based on the standards and as well as your local and state requirements and your own clinic policies. If there's information that does not directly relate to work or contains sensitive data, keep it separate from other employee documents. Use the standards manual and records worksheets to evaluate your compliance on a routine basis, maybe even quarterly have a review of your personnel files to ensure that you're meeting the expectations of what is to be contained in that personnel record. The physical environment, the clinic should be constructed and arranged and maintained to ensure access to and safety of patients. And it also provides adequate space and provision of services. Now you want to determine that the clinic has safe access. The sidewalks and parking lots are free of slip and fall hazards. Doormats and carpet runners are of commercial grade. There's proper lighting. Bug protectors are in all exposed outlets. Chemicals are out of reach of children. Sharps are secured. Live plants are out of reach of children. Light bulbs are covered. Light bulbs are shatterproof. Observe whether the clinic has sufficient space for the given type of procedures and scope of services provided, and the number of patients served. So, and the surveyors will also inspect the floors, carpet, overhead lights, cabinets, shelves, drawers, and procedure trays for cleanliness, and ensure that the hallways are free of clutter and barriers to egress. As Elsie told you, of the expectations that the facility is and the premises are clean and safe. With regard, ensure exit signs are visible and illuminated. Evacuation maps are accurate, indicating correct location and directions. All fire extinguishers are in designated locations and have been inspected routinely. Those inspections should be clearly documented on the tag attached to the fire extinguisher. Now, as you can appreciate, one of these pictures is an exaggeration, but nonetheless, a reminder to ensure the electrical safety of your facility. Sharps containers should not be easily accessible to children, and they should not be overflowing as well. So routinely monitoring your Sharps containers. Keep areas under the sinks clear. If you have an autoclave, do not store sterile items above the autoclave because moisture may seep into the packaging and the items may become contaminated. Here are some of the oxygen tank storage examples that you can, making sure that you segregate full tanks from empty tanks. So great visuals there. Now, organizational structure. There are 3 areas that must be addressed and documented. Basic requirements. The clinic must be under the medical direction of a physician, and staff meets the requirements of staffing and staff responsibilities, and have adequate written material covering organizational policies, including lines of authority and responsibilities. The written policies should consist of both administrative and patient care policies, and patient care policies should discuss the provision of services standards. In addition to including who are the proper lines of authority and responsibilities, administrative policies may cover topics such as personnel, fiscal, purchasing, and maintenance of building and equipment. Topics covered by written policies may have been influenced by requirements of the founders of the clinic, as well as agencies that have participated in supporting the clinic's operation. And finally, disclosure of the names and addresses. As Elsie described to you and is identified in some of the deficiencies that have been cited, the clinic must disclose the name and addresses of the owner and the person responsible for directing the clinic's operations, and who are the physicians that are responsible for medical direction. Now, the organizational structure are very important as part of the survey of the overall compliance of the organization. It shows, it should define the organizational structure of the clinic, and it is incumbent upon the organization to develop such an organizational chart that reflects the structure of the organization and the written materials covering the organization's policies, including lines of authority and responsibility. The surveyors will actually request to see a copy of this organizational chart and any supporting documentation that articulates those lines of authority. They will also try to make sure that they can identify the person who is principally responsible for day-to-day operations. Now, with regard to the clinic hours, it's really important that you have a sign that reflects when the clinic hours are open, what clinic hours are, and making sure to clearly outline what to do to obtain care after posted office hours, and making sure that the posted days and hours of operation are correct and accurate and posted where patients can see. The biomedical inspection, making sure maintenance for all equipment has been done and is current to make sure current with documentation to support what has been done. I think Elsie again spoke about this, making sure to document those inspections and having that documentation available and monitored routinely. This would be one of those best practices to create a preventive maintenance program. All equipment should be listed on the preventive maintenance log. Manufacturer instructions for use and the need for inspection versus preventative maintenance should be outlined. There should be a process in place for tracking due dates of preventive maintenance, and evidence of initial inspection before a piece of equipment is placed into patient use. There's annual biomedical inspection, and it's evident with stickers or by reports. And equipment that is not in use is labeled as such and stored away. Here's a great example of a chart that could be used. Making sure that the clinic has policies and documentation for equipment maintenance and inspection. And again, making sure that the instructions for use are present and process for preventive maintenance are all documented. With these maintenance lists, make sure to include the description of the item, the serial number, the date acquired, and date of the biomedical check. Now, with regard to medications management, making sure all medications are secured, organized, in date, and in original containers. This means samples as well. A single dose vial means single use. If a multi-dose vial has been opened or accessed, the vials should be dated and discarded within 28 days unless the manufacturer specifies a different date for that open vial. This is one of those areas that we do see, again, that a lot of organizations struggle with. So making sure that the multi-dose vials are dedicated to a single patient whenever possible. If a multi-dose vial must be used for more than one patient, they should only be kept and accessed in a dedicated clean medication preparation area, such as a nurse's station, away from immediate patient treatment areas. Please remember, if a multi-use vial is drawn up in a patient care area, they are considered to be single-dose vial and may not be used for another patient per CDC guideline. The RHC is required to accurately track the receipt and disposition of all scheduled drugs used in the RHC. Drugs classified under Schedule 2 are in double-locked cabinets that are secured, and staff appropriately account for all Schedule 2 narcotics daily. Now, in a memo from CMS, September of 2019, while each category, and I'm reading, I apologize, while each category of drugs and biologicals must be considered, all are not required to be stored. RHC must have the drugs, those drugs and biologicals that are necessary to provide medical emergency procedures to common life-threatening injuries and acute illnesses. The RHC must have written policies and procedures for determining what drugs and biologicals are stored for emergency services. Policies and procedures should also reflect the process for determining which drugs and biologicals to store, including who is responsible for making the determination. They should also be able to provide a complete list of which drugs, biologicals are stored and in what quantities. This is really key. That's why I wanted to make sure I read this for you, because it's so specific. And again, it is what emergency medications are appropriate to the RHC. Infection prevention, here are some of the resources and some of the expectations with regard to infection prevention, making sure PPE, hand hygiene, which I'll talk more about on the next slide, and also, designating clean and dirty areas, not reusing anything that is designated for single use. Some of the best practices here, and OSHA training and HIPAA required training as well. Now, CDC hand washing guidelines, or WHO hand washing guidelines, should be provided, and staff and providers we find are still failing to engage in proper hand hygiene techniques. So again, this is a great reinforcement for RHCs to ensure that they are following the CDC or WHO and having those resources available where staff can visualize them. One of the things that we find routinely, but just to reminds bears repeating, is the no cuts or tears and coverings. Again, this is a great visual of it, but this is something that's very easily managed. Infection prevention. Now, I will talk to you about some of the things that surveyors will be looking for as part of this during the survey for infection prevention. They will look and make sure that they're observing staff changing exam tables paper between patients. They're going to be observing staff wiping down exam tables, using a disinfecting table paper between patients. They will visually inspect exam tables, chairs, stools to ensure they're not worn or ripped. They will observe staff to ensure that staff are following manufacturer's guidelines when sanitizing, disinfecting the exam tables after each patient use. For example, using enough wipes to wet the exam table to achieve the recommended drying time that the product prescribes. They will also observe and interview staff regarding placing used linens in designated containers when applicable, disinfecting high-touch area surfaces at least daily, such as a blood pressure cuff, doorknobs, stools, chairs, disinfecting high-touch surfaces in the clinic. And are you following manufacturer's guidelines? Making sure, these are some more tips for the organization to make sure all instruments are sterilized properly. You should always check your autoclave manufacturer for specific instructions. Following those guidelines for instrument sterilization to include pre-clean instruments, so wearing PPE and that are puncture resistant and chemical resistant, and heavy duty gloves. Do not overfill your autoclave. Do not mix wrapped and unwrapped instruments. Don't use packs that are wet. Place a biological monitor inside the packs. Run a spore test weekly. And transport in a puncture and leak-proof receptacle for any dirty items. So those are some of the best tips for infection prevention. Now, there was a question with regard to mobile units, and there's quite a bit to read here, but in short, a rural health clinic can be a permanent structure or a mobile unit. So either must comply with all the conditions for certification. Mobile RHC does not have to be surveyed prior to its use. However, it must be added to the Quad A information, and that information also must be communicated to the state agency to make sure that that location is added to its information, and it must meet the location's requirements as well. All mobile units also require that they are, whether it be a permanent structure, must, let me go back again. All mobile units, regardless of whether they constitute the entire RC or a part of it, must have a fixed set of locations which the unit is scheduled to be providing services at. They must have specified dates and times, and each unit must adhere to this schedule. The schedule and times of the locations must be posted on the mobile unit and must be publicized that the patients could consult, that they can see in advance on a website or in local libraries or in stores, so forth. So this is, again, information about mobile units. These slides will be provided to you should you have want to read this in more detail. Now we'll get into emergency preparedness. And again, these are areas that I know are still area where organizations could use further reinforcement. There are 4 core areas of emergency preparedness, and they're outlined here. And just the most key thing is that they must develop and maintain a plan that must be reviewed and updated at least every 2 years. The review of risk assessment and the entire plan must be reviewed every 2 years, and the plan must have documented facility and based risk hazard, facility-based and community-based all hazards risk assessment. I guess I got tongue-tied. Includes strategies for addressing emergency events as identified through those risk assessments. Addressing the population type, making sure the types of services that the RHC can provide during an emergency and ensure continuity of its operations and delegation of its succession plan. There should be a process for cooperation and collaboration with outside entities to ensure efforts that they are integrated into the response during a disaster. These are the policies and procedures, very clearly just including safe evacuation of patients and staff that they're clearly outlined, indicating a means to shelter in place, ensuring appropriate documentation, making sure that the information is maintained in a confidential manner, as well as it is maintained in a secure manner, addressing volunteers should they be and what are their roles as part of emergency situations. Making sure to communicate, the communication plan that must be outlined includes the name of staff, name and contact information for all those listed here. I see that we're running short on time, so I'll run through these a little faster. Communication plan must include means of communicating with staff, with local agencies, federal agencies as well, communicate generally based on whatever conditions are present and location of patients under the RHC's care. Training obviously must be documented, including developing and maintaining emergency preparedness training and making sure that all new staff and existing staff are trained routinely. Training must occur at least every 2 years, and with any significant plan updates, they must include those trainings. Maintaining documentation of all training and competency assessment. Must conduct exercises to test the emergency plan at least annually, and alternate every other year. They may do testing using a full-scale exercise that is community-based or facility-based, a mock disaster drill, or a tabletop exercise or workshop. And all testing must be documented as well as the outcome and any revisions to the plan as necessary. And facilities. This is about self-assessment. I'm going to pause here just real quick to see if Elsie has any words of wisdom with regard to emergency preparedness.
The only words of wisdom that I have, Michonne, are to be sure that you document, and I repeat, document your training and your testing, and make sure that you do those exercises as required. Do a tabletop 1 year, and next year do a community-wide. If you can't schedule a community-wide, if you can't find anybody to work with you, make sure you document every effort that you've made to do that. So just training and testing and documentation are the major areas that I see problems with.
Thank you so much, Elsie. I'm gonna wrap this up by talking about, again, with regard to the self-assessments, we encourage, or we actually reinforce with organizations, they should be conducting routine assessments of its compliance. Now, one of the things I will tell you that making sure that the facility is doing these on an annual basis will help you to stay survey ready. These must be completed prior to the expiration date. It would really be taking the standards manual and Medicare requirements and going through the organization. And as I talked about earlier in the presentation, it would be advantageous to kind of split that up within your staff and allow those to act as surveyors and conduct that self-assessment and looking at records and policies and making sure that all are within compliance. Reaccreditation surveys must be conducted every 36 months. So that means our surveyors are coming on site at least every 3 years to ensure ongoing compliance. Here are some resources that are available, and we hope that you review routinely. And if you have any questions, here's my email address. You are certainly welcome to email me anytime. I appreciate the opportunity to be with you today. I hope the information I provided was helpful. And again, if you have any questions, please feel free to email me. And with that, that is the end of my presentation, and I'm gonna stop sharing my screen here and come back on camera.
Thank you, Mishan. That was great. And Elsie, that was very informative. We appreciate your time so much. I let some of the attendees know that had asked about slides that we would share them with the recording once we have it all gathered up. Let's see if anything has came in on the chat. They hadn't yet. Let's see here. Callie, do you see any questions come in?
Yeah, the evidence binder, can we have it only in the electronic format, or must we have a printed version of it as well?
The format that the facility has their policies and any evidence is the surveyor will review in whatever format they have. There's no requirement by Quad A to have any type of format, and the surveyor should be reviewing in the format that's presented.
Great.
Thank you for that question. Thank you, Mishan. That's good. I think that's very helpful to clinics that have just thought, it's always paper. And so that's good to hear. We can have electronic as well.
I will add one point. If it's all electronic, the best practice would be to have someone help drive the review by the surveyor. They're actually there to navigate, help the surveyor navigate the format and provide direction, actually drive and show where various documents are so that the surveyor can just review the documents.
We have another question from Amy Wickens. There were changes that came through to 14E2, 710, and 20 through 24. How will those impact policies and audits of it, if at all?
Okay. I actually, let's see, Elsie, do you have any insight into that? I apologize. I should have
the insight that I have is we're not going to be looking for anything different as far as the surveyors are concerned. Those were, what would you call those changes? Like Monda, she used a word to describe them, but I don't remember what it was. But you're okay on those changes. The clinics aren't going to have to worry about that. The surveyors won't be looking for anything different. Cosmetic, that's what she calls. Cosmetic change.
Cosmetic, that's good. Yeah, Amy agrees. She said, thank you. Great. They seem to be more definition. So she is appreciative of that. Thank you. Okay, I don't see anything else in the chat unless Callie sees anything. We can just keep it moving right along.
Nope, I don't see
Let's
stuff coming through.
Perfect. Perfect. Okay, let's see. Next on the list, Tressa. I am thrilled to welcome our next speaker, Tressa R. Saycree from the HSA Group. Tressa is the Director of Compliance and Education for HSA. Education is her passion and is woven into every aspect of her work. Key areas of responsibility include creating policies, developing emergency plans, facilitating hazard training, researching CMS regulations, conducting on-site compliance mock surveys, and creating forms and tools to assist RHCs across the nation. Thank you for joining us today, Tressa. The floor is yours.
Thank you. Let me go ahead and share my screen. Can you hear me okay?
We can hear you okay.
And are you seeing the correct version of my screen with the
Yes, establishing a chart audit process. We can see that.
Thank you. I appreciate the invite to participate today. And we were going back and forth on a couple of different topics for today's session, and we landed on the chart audit process. And the reason that I really wanted to bring this forward as a presentation is because we get questions quite often from RHCs across the entire nation regarding the differentiation between the collaborative reviews and the administrative reviews. And so my goal with today's presentation is to tackle both of those topics and provide processes and streamlined processes that you can implement to attack both. So let's dive into this. Our goal is, again, to understand the difference between the administrative and collaborative medical record reviews, review what those documentation requirements are, and then provide some helpful tools that you can utilize to accomplish both of these audit processes. I always like to begin with the rule, because if it's not in the law, you're not subject to it. Now, we know that there's lots of moving pieces. We have to adhere to federal, state, and local laws, but this is specifically pulled from the RHC rules and regulations. And so the first place that medical record review is mentioned is in 491.8 under physician responsibilities. And that is in regards to periodically reviewing the clinic or center's patient records, providing medical orders, and provides medical care services to the patients of the clinic or center. And then it's mentioned again in 491.8C in regards to the physician assistant and or nurse practitioner staff responsibilities regarding participate with the physician in a periodic review of the patient health records. So the reason that I brought this specific language out from the RHC law is because this helps build the structure and the framework of where we need to get to within our audit process. One element that has really heightened in awareness through surveying feedback over the last year is documentation. I'm going to say it a few times today, of both practitioners participating in that collaborative review. So not just having your physician sign off on acknowledging that they conducted those collaborative reviews, but acknowledgement signature from the APP as well that they participated in that review. We're going to dive into that in a little bit more detail later, but I wanted to bring that to the forefront through this rule here. Because it's listed under both the physician responsibility and the APP responsibility, we want to make sure we have documentation of both participating in that review. And then the next place that we see medical records mentioned in the rules and regulations for the RHC is in 491.10. And this is really the structure of what has to be captured within your medical records. As you see each patient, what needs to be kept within their medical record. And so you have to have a system in place that the clinic or center maintains a clinical record in accordance with your written policies. And we're going to dive into that piece of this as well in a little bit. Who is responsible for maintaining and monitoring records for the facility? And that you have a record for every patient that receives healthcare services. We actually just did a mock audit for a clinic a couple of weeks ago, and one of the things that we noticed is that they were going to the home of the patient and seeing a patient, documenting the care of that patient, but they didn't have a consent to treat on file for that patient because it wasn't within their normal workflow. Same with long-term care facilities or going to another facility to see a patient. regardless if it happens within the brick and mortar four walls of the clinic or not, you have to have complete and accurate records for every patient you are seeing at your clinic. So that means off-site, on-site, telehealth, all of these areas that we've expanded and been able to move into to provide access for our patients to receive care. We still need to make sure our documentation supports it and meets everything listed in 49110. Here's your list of what has to be captured. So we're talking about identification, social data, consent forms, medical history, health status, healthcare needs of the patient, and brief summary of the episode, disposition, and instructions to the patient. Reports of your physical examination, diagnostic and laboratory test results, consultative findings, physician orders, reports of treatments, medications, and this is the term that we hear quite often, other pertinent information necessary to monitor the patient's progress. And of course, signature of the provider or other healthcare professional that's participating within that medical record, making sure we have approval of that record. And of course, we're adhering to protecting that and adhering to HIPAA rules within how we interact with access and provide information from our medical records. So we thought we were done. We talked about 491.8. We talked about 491.10. Now we have it mentioned again in 491.11. So it's not just a one and done situation. It is woven throughout the RHC rules and regulations, the importance of the patient record and the audit process that the clinic needs to do in order to participate in that collaborative review, but also to determine quality of our records through the administrative record review as well. And that's really what we're relating to when we talk about 491.11. 491.11, where the medical record piece is evaluated, is during the review, the overall program evaluation includes a review of a representative sample of both active and closed records. And the purpose of the evaluation is to determine if utilization of services was appropriate, if clinic staff were following policy, and any changes that are needed. So both of these relate to not just the audit review, but that review of utilization of services, review of your policies within your clinic program to determine what changes are needed. But that chart audit is part of that evaluation to determine that. What changes are needed? We have to look at the full picture to make that determination. And the chart audit of your medical records is a piece of that picture. So here's a breakdown of how we like to define the differentiation between that collaborative and administrative chart audit. The collaborative chart audit is based on number and frequency, is based on either what your state says, or if your state is silent, what you have put into your policy. So really making sure our policies build that framework and adhere to the strictest of. If our state has a requirement for oversight, we have that listed in our policy and we have documentation to prove we're meeting it. If your state is silent, meaning you are at full scope, then you want to make sure that you define in your policy what the requirement is, and that's where your documentation will support you. So whatever is the strictest of state. If the state is silent, what do you have in your written policy? And then the intention of the collaborative review is that medical oversight between the MDDO and the NPPA. Peer review is not mentioned in the rules. It is only the review based again on what your state says, or if they're silent, what your policy says, that review between the physician and the APP. And it needs to cover all APPs. So if your state, for example, says that PAs have this oversight requirement, but NPs don't, or vice versa, we still have to capture all APPs within that collaborative review. And then maintain your documentation as proof of compliance. Flipping the other side is the administrative chart audit. Now, Appendix G says 50 or 5%, whichever is less. However, majority of the accrediting organizations allow you to determine that number and frequency for the administrative review as well, and put that in your policy, and that's what you're held to. So it just depends on who your surveying agency is, of what test you are going to be taking, and make sure that you are aware of that specific measurement for your clinic and that you're adhering to it. Again, the 55% is what's specifically listed in Appendix G, which is what you would be subject to if you were surveyed by your state. Accrediting organization, you would defer directly to their standards to determine that and put it in your policy, and that is typically what you are going to be held to. Determination on if those required elements listed in 491.10 are being met. Did we capture that consent to treat? Did we reconcile medications? Did they sign off on the record? Do we have appropriate education and instruction to the patient? We're going to dive into those details here in a few moments, but the overall review, the administrative review, can be synonymous with quality review. Based on what 491.10 says, does this record have all of the required components? Yes or no? If yes, great, we move on. If no, what do we need to do to bring that record into compliance? Do we need to talk with our reception staff about the process for the consent to treat form? Was it a provider signature issue and we need to talk with our providers about timely closing of files? What was the area identified during those audits, and then use them for educational purposes with the appropriate staff? And it should cover all providers. The collaborative is between MDDO of APP records. The administrative should also pull in a sample of your physician records, just to be sure that the elements are present. We are not looking at medical decision-making. We are looking at, are the elements present? And then making sure that we hit the target listed in 491.11 of including both active and closed records. And this one, the administrative review, is what feeds into your program evaluation to determine, again, if utilization of services was appropriate, if policies are being followed by your staff as they're working within those medical records, and if there's any changes needed to our overall program. That's part of that equation that you're determining. Now, what is a closed record? This is a question I probably get asked at least every month. And the definition really is if it is a deceased patient, someone who has transferred out their record, they are inactive based on what you have defined in policy of what qualifies as an inactive patient. Most standard is about 3 years since their last visit. So if you would treat them like a new patient if they came back to your clinic, that would be considered an active patient record. But again, you would want to define that in policy to support you in that. And then for our pediatric facilities, if they have aged out and you have defined that someone who has reached the specific age is no longer considered an active patient, they would also be considered an inactive or closed record. Now, here is what just a helpful resource for you if you are not sure what your state says regarding the collaborative review requirement, if a collaborative agreement is necessary, if there's a percentage or a number or a frequency required by your state board. This is just a breakdown state by state of what the requirements are, and so it's a helpful resource to you. The base recommendation would be to reach out to your state physician board or to your state nurse practitioner board and determine that. But this is just a helpful tool that delineates it by state. Here is sample policy language because there's no need to reinvent the wheel. This is something that you can put into place and cover both of the chart audit processes and make sure that you're in compliance with 491.8, 491.10, and 491.11. And so this is just talking about that representative sample of both active and closed clinical records. So that hits the target listed in 491.11. It defines who's going to conduct the collaborative review, which would either be your medical director or giving space for it to be designated to other physicians as well. Or designated physician will review at least, and this is where you enter that number, either what your state requires or what you have determined of advanced practice provider charts. And then here's how often we're going to do that: monthly, quarterly, whatever your process might be, to determine whether practitioners adhere to accepted standards of practice and adhere to the RHC's guidelines for medical management when diagnosing or treating patients. So this is your definition of what you're wanting to accomplish through that collaborative review. It gives you space to define who can conduct it, the number that you're going to reach, again, based on state or what you're going to determine in your policy, and how often that needs to take place. Then you have evidence that you're going to keep that you're hitting that target. So that's the collaborative language for policy. Again, you can edit this, you can make it whatever you want to. This is just a sample for your use. And then thinking about it from an administrative review, the administrative review of 50, again, if you're through the accreditors, you can edit that to fit your practice and protocol. This is based on Appendix G language. Annually, we'll evaluate whether all personnel providing direct patient care adhere to the policies. And then they'll review record review conducted by the physician if that's something that they would like to do, and includes, and then we list out what's in 49110. This is the breakdown of what we would expect to see within every medical record based on 49110. And then here's how you can streamline that process, because I am all for, if I'm gonna do the work, just make me do it once and let it be done. And so a way that you can streamline that is to utilize the process and streamline your process and define who's responsible for each area. So update your written policy to reflect the number and frequency of the collaborative review, and make a generic language to cover all APPs if your state allows you to do that. So an example of that is the clinic will pull 10 records for the medical director or designated physician to review. That 10 could be covering all APPs at your clinic. That really depends on how many providers you have at your facility. If you have 3, 4 providers, that number is sufficient. If you have 5, 6, 7, you want a couple of records at least per APP to really determine that you have done that collaborative review appropriately. Update written policy to reflect number and frequency for the administrative review. And it needs to include all providers like we already mentioned. And then define who's responsible. This does not have to fall to a physician. We see managers take this role on. Sometimes HIM department is already doing a coding review. So they bring in specific elements to make sure they're hitting all of the areas of 49110 within that coding review. You can determine who does that as long as they're qualified to do so, and that they've been trained on what to look for within your system. The title, so you edit that element, will then conduct the administrative review of 15 records per quarter to confirm the required elements are present. You can pull those same 10 records from the collaborative, pull in a couple of physician records and 1 closed record per quarter, and then that would be considered your administrative review. Then keep those reviews each quarter and keep those for when you conduct that program evaluation, whether you do that on an annual or biannual process. This is just a sample of how some clinics have streamlined that process to tackle both the collaborative and the administrative review. Now, this is language directly from Appendix G defining and supporting where my conversation is coming from. So the chart audit process, this is specific to 491.8. A physician, so an MDDO, must review periodically the RHC's patient clinical records. In the states where state law requires a collaborative physician to review medical records, co-sign medical records, or both, an RHC physician must review and sign all such records. So you have to adhere to your state if they require co-signature. If there's more than one physician, it is permissible for staff physicians and others to review and co-sign those records. It doesn't all have to fall to the medical director, as long as you have put that allowance within your policies. The RHC's NP and/or PA must also participate in the physician's review of the clinical records. Participation can be face-to-face. It can be via telecommunications. So there's a lot of ways to tackle that collaborative review. If there's more than one NP or PA in the clinic, the NP or PA would only participate in the records relevant to them. And this red language here is where it comes to if your state is silent, then that's where your policy supports you. So where co-signature is not required, the regulation still requires periodic physician review of the clinical records for non-physician practitioners. And so again, just really making sure you are aware of what your state requires for collaborative reviews. If none, then you define number and frequency in your policy, and that is what you are held to. And you would need to be able to provide documentation to support that and prove that it's taking place based on your written policy. One caution I do want to give here is some clinics utilize their EMR system to track co-signature. And so really making sure that if you are utilizing your EMR system, there are systems that are robust enough to be able to meet that requirement. However, I would caution you and have you do a self-assessment of that and determine, can you pull a report to determine that you are able to show you met that number and frequency and that both providers participated in it and that there's space for communication and collaboration and notes. So that would be my caution to you. If you're using your EMR as proof of that collaborative review, run a report and see what information you have available. Is there space for both providers to sign off and document participation? Is there space for communication? And can you prove that you're meeting the number and frequency in your policy and or what your state requires? If your EMR does not have that capability, you can work with your EMR vendor and see if that can be built in a specific reporting process, or you can utilize some manual tools that we will provide to you here in a moment. If you have more than one physician, then your policies, this is where your policies come in and support you, and it's just supporting what we already shared. It does not specify a particular time frame, so that's where you get to choose frequency and put it in your policy, and that is what you are held to. Here is a sample tool that you can utilize, and I believe these slides are going to be made available. And so make sure that if this is something you want to use, go ahead and grab that, create your own version of it that you can manipulate and add your own logo to. But this is just a helpful tool that clinics have utilized to document both providers participating in that review. It gives space for determining what month you can update that to the quarter you are conducting this review on. It gives space for the names of the participants in that review, and it gives space for both documents to document what records were included, what notes there were, and gives space for the physician to sign, and provide space for the APP to also give feedback and sign off acknowledgement of participation as well. So this is one version of the form that we have seen clinics utilize and put into practice and work within their clinic structure as evidence that you're meeting what you put in your policy. Here's another form that we received in the last few months that we find very helpful as well. Again, it hits the same targets. It's just a different format, and you can utilize it, update it however you see fit. It gives space for what's going to be reviewed, gives space for comments, and gives space for both providers' signatures. Then we're going to move on to the administrative piece. And this is in relation to 491.11. Must include a review of representative sample of both active and closed records. And this is where we get that definition of who qualifies to do the administrative review, and that's the blue language at the bottom. The evaluation of whether the RHC's patient care policies were followed may be conducted by an MDDO, a non-physician practitioner, an RN, or other. So there's a lot of space within that term, other personnel who meet the RHC's qualifications criteria. And this is where that 5% or 50 language comes from. Again, this is specific to Appendix G. If you're through the accreditor, please review their standards and write in your policy your determination of number and frequency, and that's what you will be held to. But according to Appendix G, so those who are under the state, the purpose is to determine whether utilization of services was appropriate, and if your providers and other staff members, those who are taking vitals, etc., are following patient care policy. And here's a sample tool that you can use for the administrative review. I do not like to include any patient identifiers, anything that would be considered PHI within my audits when I'm doing an external audit for a clinic, because we want it to be something that they can have available for educational purposes within their staff. So we just identify who the provider was that conducted that visit, what the date of service was, and then some form of either an MRN account number, something that allows us to go back and look at the specific record if needed. But then we look to see, are the elements present? So the chief complaint is really supported by HPI, making sure that we have a definition of why that patient is at the clinic. And then the consent to treat, did we capture the consent? If it's a minor patient, do we know that the person signing that form is allowed to do so? Is it complete? And then if our policy says a time frame for obtaining consent, does our records reflect that being completed? So that's what we're looking for when we look at consent to treat forms. And does it have the medical disclaimer in it? A lot of times consent forms that I'm reviewing for clinics, it's just the financial pieces. There's no actual statement giving release of giving permission to the clinic to provide care. Excuse me. And then social data, making sure that that is captured within the medical record. And then history, of course, of the patient based on that visit, making sure that we have documented history. Provider signature, more and more I'm seeing this area in not getting completed in a timely manner. So if your policy says a duration of time that providers have to close their records, making sure that when we're doing our administrative reviews that we're hitting our policy target, and that our providers are signing them off in a timely manner. And then there are a couple of loops that we really want to make sure we close. One of them being labs. From if you are ordering outside labs, we want to make sure that full circle is being closed. From provider order to the results to the patient, that full loop needs to be documented. So we have the provider order, the order being filled, the results coming back, provider review, and then documentation that the patient received that result, especially if it's an abnormal result. We should see documentation that they received that result and treatment plan based on that. And then the loop that we also want to see closed is in regards to consultative findings. So when you're doing a specialty order, from provider order, authorization release, prior authorization, your scheduling of the appointment, all the way through until that consultative note comes back into the record. We want to make sure we're closing that full loop and not just closing it off once that referral is sent, but we're following it through until that consultative note comes back into the record. Now, usually this is where I hear a few gasps. And so I want to give you some clarity that you are not responsible for babysitting your patients. You are responsible for documenting your due diligence within the system. So making sure if you're calling a patient that you document that within a telephone note in your medical record. If you are sending it into your patient portal, that's documented within your medical record. You are documenting your due diligence on how you are following up with your patients. And then instructions to the patient. The patient, when they leave your facility, should know their next step in care, and it should be documented. We know providers are having these conversations with their patients in that exam room. We know they're doing an amazing job with their patients. Otherwise, those patients would not be coming back. But we need to have the documented proof of that in your medical record. And that's what this audit is really looking for. Do we have documentation of education to the patient, instructions to the patient, beyond just a new medication being prescribed? When that patient leaves your facility, do they know their next step in care? And is it documented? And then evidence of follow-up. This is really meant to be, this is your business. This is your way of bringing patients back into your facility. If a provider says they want to see a patient in the next 3 months, maybe they are a diabetic patient and they need to have their A1C checked again, then we should see something within the record that has that scheduled. Now, I am probably the worst at that. I never know my schedule 3 months out because I'm traveling. And so I tell them, I'll call you and let you know. It's wonderful. But as much as possible, really making sure that you're capturing those follow-up visits and getting them into your schedule as much as possible. And then within each record, making sure that we're reconciling medications, their medication list, and then if you're administering anything within the clinic, making sure that those get documented appropriately. And allergies, of course, as well. If they have known allergies, what is the reaction, and making sure that those are documented within the system. What I like to do, and I don't know if you can see my mouse or not, but I like to make this a 15 record review and this is what I do for the entire quarter. I pull 15 records, 10 of which were those APP reviews. I review those same records from an administrative standpoint. Are the elements present? I make notes of anything that's missing so I can go back and talk with the appropriate staff about that. And then number 15, I mark as closed, and I make sure I locate a closed record, and I define why it's considered a closed record. And that's just my way of documenting that I hit that target. So when I get to my program evaluation in 2 years' time, I'm not having to go back and redo work. What are some common deficiencies? Probably the biggest deficiency that we find anyway is missing documentation, missing evidence. We don't see proof of both providers participating in that collaborative review. When we're doing the administrative audit, there's pieces missing based on maybe the consent form isn't up to date or is missing altogether. Maybe it's sitting in a scan pile because we're short-staffed. Where is the evidence that we're following the protocols we've put into place? Or we don't have a process, or our staff are unfamiliar with the process that we have defined in policy. And a lot of this really does have to do with staff turnover and making sure that as we bring new people into our clinic, because that seems to be the trend that is happening, as we bring in new staff into our facility, we have appropriate orientation on what the expectation is within their role. And we are sure that they understand, here's our workflows, here's how we label documents that we're scanning and uploading, here's where it's going to be scanned and uploaded to. As you're bringing in a consent form from a patient, here's what to look for before they leave our building to be sure it's complete. And really making sure that our staff have all of the tools that they need to be successful within their process. And then consent is often incomplete or missing. One of the biggest components here is clinics have put themselves in a box with their written policy saying that they're going to keep a consent every year. The base requirement is upon initial visit or as information changes. An example of that is a minor patient coming into adulthood and needing to sign their own consent form. You'd expect to see a new consent on file at that time. But if you're putting it in your policy, that's what you're going to be held to. So we recommend updating your policy to allow for, as long as you have that initial consent, a yearly process is a great standard of practice. But if you have it in your policy, you have to adhere to it. And so really making sure you're not putting yourself in a box with your written policy, and your staff are aware of what your policy says and trained on expectations. Another thing that we commonly find is instructions to the patient are not being documented, and follow-up with the patient is not sufficient or is missing within the overall record. Now, what I do find is often when I sit down and talk with a provider, they're able to show with me exactly what happened with that patient in their visit, but I don't have it from the documentation side of it. And you have to think, when an auditor comes into your space, they're looking at your documentation. And so that's how they determine if you're following policy, if you have everything needed to be able to consider that a full visit. And so really making sure that it's not just being done in the exam room with the patient, but that it's getting captured in your documentation as well. We already talked about these loops. One thing I do want to mention in regards to imaging is we want to follow that same protocol from provider order all the way through to the result to the patient. And where we find deficiency happens commonly is if an image is ordered and then there's something abnormal about it, and we don't have proof that that patient was ever notified or brought back into the clinic to continue their care plan. That's a patient safety concern, and we really want to make sure we are able to document and keep our patients as healthy as possible, really. What are some roadblocks? So one of the things that I have noticed, especially with scheduling availability, is more and more clinics have smaller blocks of availability for walk-in patients, or if someone calls with an acute visit need, having availability within their schedule can be difficult to accommodate them in a timely manner. So as much as possible, leaving blocks throughout your system or having availability to squeeze someone in if needed and just thinking through how you set up your templates and your workflows and your timeframes to allow for scheduling availability within your system. Staffing levels is another impact on why that schedule may not be as available as you want it to be. Maybe you don't have enough support staff to keep the clinic running efficiently. And so really addressing those staffing needs as they come. Policy development, we don't know what we don't know. And so policy really helps you to build that framework of what needs to be completed within the clinic in regards to those audit processes. Use that sample language if that's helpful to you. Develop your policy, train your staff on the policy, implement the tools that you want to use to document that policy is being followed, and go through that process. And then often with patients, transportation is a big barrier to care. And so what can we do within our community, within our resources? Do we have access to be able to get our patients transportation to our facility? Or if we're referring them into specialties, transportation is a barrier, and having that as a consideration as we're scheduling out and as we're following up on our referral systems, transportation is going to be one of those things that we have to consider and talk through. And another barrier a lot of times for patients is you might order something to a specialist, but insurance won't cover it. And so that's going to be something that prevents them from going and having that service. So these are just common roadblocks that we find. Some of your safety nets of why patients come back to your facility and allow you to keep up with that follow-up for patients is medication refills is honestly one of the biggest ways that patients continue to come back into the clinic, because we need to have that face-to-face visit with the provider, and we need to make sure that we're following their care, that we know what their next step in care is, and medication management is part of that. Having the appropriate tracking tools. So if your EMR system allows you to track where you are with referrals and labs and imaging, and you can track that full loop from provider order through result to patient and consultative note coming back into the record. If you have tracking tools allowed through your EMR, that's wonderful. But if your EMR doesn't have that, talk with your vendor or develop manual processes that you can do to track those systems. Chart audits, again, that quality review of are the elements present, that administrative review helps you to know that your staff are adhering to your policies and are following up on elements as needed. Staff training, getting that documented. Here's what our policy says, here's your role within that, and here's the expectation, and let's document training of our staff on those elements. Some clinics bringing in a referral coordinator pays for itself, because they are constantly tracking those documentations, making sure authorizations go through, that we have a scheduled appointment, that our patients are not falling through the cracks. And then care management services, I know that that has expanded in the last few months. I am not going to dive into the detail on that. That's not my space. But that is another way of making sure that we have appropriate follow-up with our patients and we're keeping track of where they are and where we want them to get to. How do we do that? Your EMR is really one of your biggest support tools. And if it's not working for you, reach out to your vendor and see if there's a way to build out your templates, to build out your reporting processes, and to capture the information you really are needing to be able to conduct each of these actions. One of the biggest things we find when we conduct a program evaluation for a clinic is it can be difficult to locate a closed record. Sometimes they have to go to their HIM department and find a record release request along those lines. So I would work with your EMR and see if there's ways to build out what reports you can pull to determine a closed record within your system. Spreadsheets, I am all for Excel spreadsheets and creating tools. If my EMR doesn't support me, I'm going to create my own way of tracking it. Those audit forms that I provided, you can manipulate those to fit your workflows and processes as much as you need to. Patient portal is another way to document results being given to your patient. Patient summaries is a way to document that your patient leaves knowing what their next step in care is. These are helpful tools, they're not necessary. And then program evaluation report is a way for you to determine how are we doing? How are our records? Are we hitting our goals? Are we following policy? If not, what changes do we need to implement to improve in these areas? So let's break this down into one streamlined process. Your first action following this would be to look at your written policy. What do you currently say is necessary for the collaborative review and for the administrative review? Do you have a written policy on those actions? Is it somewhere within a collaborative agreement? Is it in your provider contracts? Is there a written policy? Something defining that expectation, number, and frequency. So update your written policy, and there's sample language in this presentation that you can use if that's helpful to you. Then develop your tools needed to support that written policy. Again, we've provided a couple of options for audit tools for both the collaborative and the administrative reviews, but develop your tools that you're going to use to show evidence that you're meeting your written policy that you just updated. Then once you're finished with that policy, train your staff how to utilize the tools, how often they need to be completed, make sure that they are aware of where to find and locate that information, where are we storing evidence for this information, and just bring all of your staff on board with this initiative. The more involvement, the more understanding, the better the result. And so what I find very commonly when I'm doing an administrative audit is I'm looking, and if it's a consent to treat form, then we have a sit down with receptionists and we go through the process. Here's what we found. Here's some ways that we can correct this area. And we just have that staff one-on-one discussion regarding the element that's relevant to them. Maybe it's patient demographics. It might be the intake process with our clinical support staff, making sure we're capturing correct vitals and everything that the provider is going to need to determine care plan. If so, then we have a sit down with that relevant staff. Or it could be providers. Maybe they don't have enough support and so they're not able to close them in a timely manner, or they need more administrative time to be able to complete that action. Or maybe we need to set up our templates to be more user-friendly so that they're not taking as much time to complete those actions that we need them to do. So really making sure we're having those discussions with the relevant staff members. And we like to say, if you're going to do the work, make it work for you. And so reviewing the results of these administrative audits can just help improve quality within your clinic and bring staff on board to why we're asking for this information. So review the audit results with relevant staff and repeat this every quarter, month, whatever timeline you've defined in your policy or based on what your state requires. Make sure that you are keeping up with that ongoing requirement. And then, of course, maintain documented proof of those completed audits. One element that we are finding, especially for clinics that are working with an ACO, or if they have specific payer metrics, quality metrics that they're wanting to obtain or to reach, is as you're pulling those records each quarter or each month, whatever that timeline is, pull a specific focus. So an example of that is we had a clinic that was wanting to improve their vaccine rates for children under 2. And so when they did that quarterly administrative audit, they pulled records specific to that quality metric. So they pulled a report based on patients under 2, and they determined if they had done their screening process, if they had captured vaccines within that visit, to be sure that their vaccine records were up to date or what communication went to the patient based on that. And so there's ways to utilize this process to hit many targets. So if you have specific payer metrics, if you have specific quality metrics that you're working on for some of your initiatives or performance improvement projects, use that as what records you're going to pull to conduct these audits. Because that way, you have a more measurable tool of how you're monitoring and improving in each of those areas. It's just a recommendation. It's not something you have to do. It is just something that we have found very helpful for clinics as a streamlined process. Now, I do want to leave some space for questions. My email is here on the screen. Please email me if you have any questions, but I believe there were a few things that came into the chat as well.
Thank
you, Tressa. I am looking through the chat now. And there was just some back and forth if we could share the forms and things. And yes, I had let them know that we will be sharing the forms when we share the slides and the recording.
Thank you. And if people would like, I
go
can
ahead.
send the Word version of those. That way they can edit them as needed.
That would be great if you don't mind.
Sure, I can do that. I know how hard it is if you don't have the right software to try and edit a PDF or a picture, it's nearly impossible. And then you're having to retype everything. So I can send the Word version for that.
It is true. Thank you so much. Let's see here. So one of the questions, Tressa, is how long should we keep the documented proof of completed audits or staff trainings?
So normally my recommendation is from survey to survey. And if you're with one of the accreditors, that's actually pretty simple because you're on a 3-year survey cycle. Sometimes states are a little bit longer in duration. And so then I would adhere to the medical record time frame of 6 years or whatever your state requires for maintaining records. But I typically see a 3-year rotation within that capturing of evidence.
Perfect. And then that can be electronic as well, not just
Correct.
paper. Perfect.
Mhm.
Perfect. Yeah, let me check one more
Yes, the
time.
electronic storage of information is wonderful
Yes.
and is usually much more user-friendly and something that you can navigate. If that's not something that's available, then paper can be a supportive way to do that. But the more electronic you can go, the better in my mind.
Yes, absolutely. We see the slide that you have a link for the states. So
Yes.
if a particular state has a question, they have the resource there.
Yes, and so that what that does is, I'm gonna see if I can go back to that just a minute. It brings up and if those links don't work, I can also send the process there. I don't know if that's gonna pop up on my screen. Nope. So what that does is it brings up the rules and regulations, and it's not gonna let me do that because I'm in presentation mode. But it breaks it down by physician and or physician assistant and by NP. Let me bring up an example. Can you see this screen?
Yes.
So an example of that is Indiana. You can see what the requirement is for that state. Advanced nurse practitioner is a physician involved requirement, and this says yes, a collaborative agreement is required. And so this just breaks down by state what the requirement is per license type. So this is the nurse practitioner version of that. And then you also have the PA rules by state. Let me bring that over. Can you see that document now?
Yes.
And so this again is just broken down by state of what the requirement is, what documentation support is necessary. Some have a percentage listed. And so if your state has a percentage listed and a frequency, then that is the expectation of what we would hope to see within your policy and within your practice documentation. So that's what those links should lead you to. If for some reason those links are not active or not working, I tried them before I sent the slide, so I'm hoping they're acting correctly. If they don't work, please let me know and I can provide those documents specifically.
Perfect. Thank you so much, Tressa.
Any other questions?
Let me just triple check here. I don't think so, but yeah, I think that's everything. I appreciate your time today, Tressa, very much so. It was very informative. We have your contact there if somebody needs to reach out personally to you. And of course, at the beginning of our session, we had explained anybody can send emails to us, and then we'll, of course, get that sent your way if for some reason they email us and not you. But we will pass that out to the group as well, because if somebody asks a really good question, then we'll want to pass that out to everyone.
That sounds great. Thank you so much. I appreciate being part of today.
Yes, thank you. Okay, let's see. Well, we got about 10 minutes. We've been on pretty solid. If you guys just want to take a quick bathroom break or a drink break, we will have Charles start Charles James start at 1 p.m. It looks about to be 10 till now, so we can just do a really quick break, and I'll see if I can find us some Jeopardy music. As we get back from our break here, I can go ahead and start the next introduction here. We're going to welcome everyone back. Make sure I'm off mute. I think we're good now. Okay, welcome back, everybody. As you're trickling in, I am pleased to announce our final speaker of the Lunch and Learn. Extremely excited to hear Charles James from North American Healthcare Management Services. I've had the great pleasure, as most of you, in hearing Charles on billing webinars and educating us through different platforms, such as the National Association of Rural Health Clinics and other entities. But Charles, you should be able to share your screen and take over. If not, let me
Can you
know.
hear me?
I can hear you.
Excellent. I'm going to leave my video off because indeed, I think that kills a lot of people's connectivity when we have so much video going.
Yes.
But thank you for the kind introduction. That's really very nice and makes me a little embarrassed, but thank you all the same. I'm very happy to be here speaking with you and the Burrows group. See a lot of faces that are a lot of names that I'm not familiar with. So it's great to be speaking with some new folks. And of course, some very familiar faces as well. So Elizabeth and Melissa, thank you very much for inviting me to attend today. Let's dig right in. I had given this presentation in Kentucky, and I think Melissa was in Kentucky. We saw each other somewhere. I think that's where it was. And since then, we've actually had some pretty serious updates. I'm stammering with my words because I'm not sure if they're updates. They're updates. We've got some CMS proposals that we're going to talk about in the context of a lot of the issues that we're facing relative to behavioral health and some of our, particularly when we get down to our G codes, but particularly behavioral health and primary care. So if you haven't looked at the CMS proposed rule yet for 2025, go take a look and just pull the thing up and Google, search RHC in there. And there's quite a bit of material, particularly with billing, on a lot of the things we've been talking about. And I better be quiet and get through this because I think we have a fairly limited amount of time. So new behavioral health providers, behavioral health telehealth, our primary care problem, some care management issues, forget the remote monitoring. I hacked that out. G code and intensive outpatient therapy. I have quite a few slides and I'm not going to linger very long on many of them. This, as we know, is probably most of us know this is old news. We've had an expansion of our behavioral health providers who can see patients on the same level. They're rural health clinic providers, just like a physician, just like a nurse practitioner, just like a PA, social worker, nurse midwife. For a long time, many states were out front of the feds, and in particular, LPCs, which are a mental health counselor. They fall in that MHC category. LPCs, certified professional counselors, licensed professional counselors, licensed professional counselors, really without that clinical piece, but they weren't rural health providers. Now they are. A lot of states call things different titles. Kentucky has some different professional registrations than Indiana, even though they're effectively the same. The name's a little different. So Medicare defines these as, you can see on the screen. I'm not going to read them all to you, but basically your master's or doctoral degree and then 2 years of clinical supervision afterwards. Mental health counselors includes quite an array of folks that we did not see included before. This prior slide was marriage and family therapists. So that's big. Mental health counselors, like I said, this gets us to the LPC folks, CPC folks, professional counselors. Were not previously behavioral health providers under Medicare, now are. So this aligns now with most states. Some states still don't have this yet. Many do. a lot don't. I know I called out Kentucky. Kentucky was way out front in some of this. Ohio, Indiana, many of our Midwestern states, but I don't think Missouri has. Don't quote me on that. Missouri, don't hate on me. But check your state to make sure that they've made the same expansion. You know, we could do this, we could bill these providers under general supervision prior to, but now they are approved providers just like anyone else. One more comment on these providers. There's a lot of argument about it, but I'm sorry, I just got a phone call on the other screen and now it's totally distracted me. These providers can be your provider in terms of operations. You know, if somebody shows up, we need a provider there to be able to see patients, and our LPCs and our mental health counselors count as that provider. Now, there's some pushback on that from particularly accredited. I don't want to say from whom, but for example, Kate Hill, she said it very publicly that she disagrees that that's a safe situation where people don't have emergency training or are approved providers. But so be it. Right now, all of our approved providers establish a provider's presence so that we can provide, there's way too many uses of word providers, so that we can offer patient care service to our patients, i.e. we can be open with any of these providers. This is actually old news too. What constitutes a visit? 405-2463. What constitutes a visit? When you get these slides, you can see I've got these all nicely linked here. And these are our rural health definitions. Tressa focused on compliance issues, but this 405 code is where we get all of our definitions. One of those definitions is the fact that now a behavioral health visit, an encounter, a mental health visit is a face-to-face encounter if it's furnished using real-time audio, video, telecommunications, or in our case, telephone only. This is a rural health clinic visit. A mental health visit via telehealth is now an encounter. So all that G2025 business goes away for behavioral health visits. We're just going to bill them just like any other visit. The in-person requirement for telehealth visits, behavioral health visits included, is still delayed. We're going to talk more about that momentarily, but still delayed. We have a broader telehealth question. Actually, I think I may have cut it out of this because I didn't want to talk about non-behavioral health telehealth. So right now, in-person visits delayed until we have a broader resolution of our telehealth issue. These are the qualified visits for behavioral health on the qualified visit list. We have 7 of them. 7 of them. Standard behavioral health clinic, behavioral health service, rural health clinic bill. 0900 over here differentiates our claim as a behavioral health visit. We have the CG modifier indicating that this is an encounter, basic in-person behavioral health visit. We have telehealth behavioral health visit. You can see right here, TH. We use a 95 modifier. Those are encounters. The provider can be at their home, patient can be at their home, as long as that provider is on the rural health clinic clock and being paid by the rural health clinic, it goes on the rural health clinic cost report, it's an encounter. Now, if the patient is at the clinic and the provider is at home, that's really an originating site thing, but we don't want to go down that rabbit hole. Let's just say for telehealth behavioral health services are encounters. If it's audio only, see down there on the bottom, we still have revenue code 0900. We get a modifier FQ or 93 to indicate audio only. Neither of those make any difference in payment. Remember, one of the occasions where we can bill 2 encounters on the same day is when we have behavioral health visit and a clinic visit on the same day. Number 2 there, see the nurse practitioner, family practice nurse practitioner, and they have a visit with the LCSW. That is 2 encounters, and that's how we would bill it. 0900 differentiates the service, and the patient is going to have coinsurance on 2 encounters, we're going to get 80% of the rate 2 times in this scenario. You know, this whole issue of rural health clinic comes from the Social Security code right here. And it means rural health clinic is primarily engaged in furnishing outpatient services, and look below, not a facility primarily for the treatment of mental diseases. So that's really messed us up in a lot of ways, because that's caused this interpretation, and that's what it is. It's from the State Operations Manual, SOM Appendix G, that is by definition CMS interpretation of the statute. And all of our opinion is they messed it up when they interpreted it like they have in this whole 51% comes from a primarily engaged term that CMS went and said, okay, we're going to interpret that to mean 51% of our services have to be quote unquote primary care, and no more than 49% of our visits can be behavioral health. Excuse me, I said of our visits, they interpreted it by provider hours. 51% of provider hours right now must be primary care. So that our current RHC compliance, big flasher there, right? Current with an asterisk. We have to treat all patient conditions. We need to have our documentation reflect this. We do not treat solely psychiatric conditions in our rural health clinic. And we have to ensure that psychiatric services, or frankly, any specialty services, don't exceed 49% of total provider hours. Now let's talk about this for a second, because a Suboxone clinic. What is a Suboxone clinic? Is it to administer medication, or is it to follow up with substance abuse disorder? They're 2 very different things. If I'm here administering a medication and I'm calling myself a Suboxone clinic, Houston, I think we have a problem. We're following up on substance abuse disorder, and we have medically assisted therapy, and the patient has an entire write-up with all of their primary care conditions, then we're talking about a different thing. If we're talking about cranking patients through a Suboxone clinic and everybody has anxiety or whatever, mental health diagnoses as their primary diagnoses, and we're just cranking out Suboxone all day, yeah, that's going to be a problem. That's why all of our patients for primary care or behavioral health services, we do a full primary care write-up on them, and then we deliver services according to their care plan. I stupidly keep looking at my camera through this like I'm talking to you all. It's now we've forced that habit post-pandemic, right? So what do we do with all this? We can't have a presentation and not cite the founding fathers to gather everyone's attention. So an ounce of prevention is worth a pound of cure. We need our own behavioral health policy. If you have behavioral health services, have a policy that defines what are your behavioral health services. This is one example that we use. I like them nice and neat. Note down here, MD primary care services for all patient diseases during which some behavioral health service conditions may be addressed. I'm not saying it's a great policy. My point is have your own behavioral health policy and what defines behavioral health. And of course, in your rural health manual, you probably have job descriptions for each of these professional types of what an LPC is going to do versus what an advanced practice nurse is going to do versus what an advanced practice nurse with a psychiatric specialty is going to do. Did you catch that? LCSW, advanced practice nurse with psychiatric specialization. We probably need to have those clearly defined so that we determine what of those services that we just discussed are primary care or not. Now, here's the thing. Here's the proposed rule that I just talked about. I've got it linked. That's the Federal Register, got it double linked. Down here, this is not linked. I wanted to highlight where it is. And RHC has some comments and interpretation. I've included some excerpts here. So first, back to mental diseases. Primarily engaged in primary care. I just skipped from first to third. And then our telehealth clarifications. This is, I just picked and chose some of the components of the proposed rule that are highlighted in National Association's comments. And these are a few of them. How do we define mental diseases to support RHCs that offer behavioral health services within the confines of outdated statutory language? What does that even mean? How do we get behavioral health services? And how do we get around? Because if I back up, I'm not going to back all the way up. One of those is out of the statute, US code, that says cannot be treat primarily mental health services. It's in the code. Some of these are more in final rules, which are easier to change. The telehealth policy is embedded in final rules. That's easier to, oh, now I just said that. I said that's easier to change, but we're relying on congressional action to change it. And then some of these others, CMS can take unilateral decisions on. So this is some of what's in the proposed rule. So let's talk about the mental diseases. I like to highlight an episode when I was in, I think, late middle school, that, and I think it was with a church group, but I'm not sure about that. It may have been with a class. And we went to, it wasn't our mental state hospital here, which is quite the institution. I can't remember where it was, but they had a big mental health ward. I think it was the state hospital or a side building of there, where they had the mental retardation ward. Severely were restrained in their beds. Moderate were in bed and drugged, catatonic, and then, you know, the mild were kind of zombified, walking around rooms. Here's my point. That was 8 years after the Rural Health Clinic reg was written. So the reg was written using completely antiquated thought processes when diagnosing and treating mental illnesses were at a totally different stage of existence. And we still use the term mental retardation. I think, my God, who did they have? Excuse me, my goodness, who did they have restrained in that ward? You can never tell. So we've come a long way. CMS is wanting to know what types they want comments. So please go out to the final rule. I'll show you where a link is to it. They want comments to say what types of behavioral health services are being offered by RHCs and how often, basically, what do you need? Provide comment. What can we do as CMS? They're asking for comments. These comments can absolutely change policy. So please go out, comment. I won't tell you what to comment, but I'll tell you what I'd like you to comment. How about that? Is we need behavioral health to be considered primary care and not mental health. We need it primary care because think about, I have a provider who showed up who's telling me about the people out in Southern Kentucky that show up using Trank. And Trank is the next thing, is some kind of horse tranquilizer. I guess they're injecting themselves with now. They're mixing with all kinds of stuff, but it causes gaping wounds down to the sinew and the bones that, of course, get infected. And that's not just in it, you know, that's way beyond. So CMS is looking for comment. Here's the other thing. Substance abuse is primary care. We can have arguments about it with psychological journals. I'm not smart enough to read psychological journals because I'm a lowly MBA and I don't have any clinical experience, but here's what I know. Your comments out here will help change this. And I know how a lot of you will comment. Please go out and do that. That's where to do it. You go out, this is a picture of it, and it's super easy. Just go submit a formal comment on that site. Define your own policy. What are behavioral health services? APRN, doing a med rec is not necessarily behavioral health. And oh, by the way, that MedRec is already part of an encounter and not an encounter by itself. So what providers are behavioral health? What are your psychiatric advanced practice nurses doing? How do we define their services? How do we split them between behavioral health and primary care, et cetera? So get your own policy defined regardless of what happens with the proposed rule. CMS proposed rule has gone on to extend till 2025 the telehealth changes. But remember, that's just for behavioral health, just in terms of in-person visits. For clinical visits, it's the G2025 that we still have in place that really is the biggest impact of this extension. But I don't even want to talk about that other code that I just mentioned here because it just confuses things. Because behavioral health, we do not use that code. We use our regular HCPCS code, one of the standalone encounters on the qualifying visit list, and revenue code 900. And that's for in-person visits, and it's for telehealth too. It's the in-person face-to-face visit requirement of every so often that is waived right now for all of us. A lot of us know that we may or may not know that we have, and this is actually, you see this in 23 definition of what's included in our care management services. We've had a dramatic expansion of what's included in care management services, but we also have had this whole time a lot of behavioral health services already included in what we can do. So, you know, we have this G0511 code that is the weighted average of all non-facility physician fee schedule payment rates across the country. Is how we come up with the G0511. Right now, we can bill, if you have a patient, we're going to talk about some behavioral health care management services, but if we're doing transitional care management, we can bill these at the same time now. Our G0511 that we are very familiar with as the 2 or more chronic conditions on the clinical side. On the behavioral health side, we have 1 or more new or pre-existing behavioral health or psychiatric conditions being treated by the RHC that include substance abuse disorders, which in the clinical judgment of the provider warrant behavioral health intervention. That's a big deal. So G0511 applies to behavioral health. Option B requires that we use an initial assessment, follow-up monitoring, validated rating scales to assess the patient, and we have behavioral health care planning related to their psychiatric conditions, et cetera, et cetera. This is what we're doing here. This is care management. We're facilitating, coordinating treatment, and we're ensuring continuity of care. We're coordinating and facilitating. That's what care management is. Now, we also have this elevated level of care management, which is not the 20 minutes, it's 70 minutes of the first month and 60 minutes in each subsequent month to qualify for payment. And this is, I don't have it highlighted up, G0512 right in the middle of the page there. G0512 is our collaborative care management for RHCs and FQHCs. We need an initiating visit within the past year. And again, at least 70 minutes in the first calendar month, 60 minutes in subsequent months under the direction of our RHC practitioner, as well as our behavioral health care manager. And those are G0512s. Those are our payment amounts. $144 for the G0512. You see those actually went down. G0511 went down substantially. You know why it went down? Because we added a whole bunch of services to the basket. That's why we can stack stuff on the remote monitoring. The only place, oh, I didn't put where we get those. It's out on the CMS Rural Health Center website. It's the only place those get published. That's what the claim looks like, G0511, G0512, whatever it is. You can bill those with or without an encounter. and you'll get the 7171 right now. And we can also talk about a care assessment and initiation, and that we would bundle. So this would be to initiate the care management, but we can bundle that with our office visit. Trying to think through my claim here, stumbling over my words. So we can I'm looking at the math, making sure that math is right. So it should be. And then of course the $404 is not relevant, but the patient's going to pay copay based on the CG modifier line, and the G0506 is bundled up with a $230 some odd dollar, $240. Yeah, $240, 99214. So that's one of those time-based codes. Guess what? We're about to throw all that out the window with our G0511s and G0512s. Because look at that first paragraph. CMS heard our concerns and is proposing to allow us to just bill our individual codes and do away with the G0511. There's zero resistance to this. And guess what? Everybody figured out that, especially with remote monitoring, and especially with us being able to stack the codes with remote monitoring, doing multiple G0511s in a given month, we come out a lot better on G0511 than we do just billing the CPT code. So this one we'll go through. G0511 is we know it, in my view, will be done as soon as this proposed rule becomes a final rule, because there's zero resistance to it. And then on the other hand, it sure takes a lot of complexity out of things. And look at the bottom one. This change means RHCs will be eligible to bill for add-on time-based codes too. Now, what does this mean? No one knows. Does that mean we just go back and all those codes that are in G0511 basket, we put on a UB04? Unlikely, because I don't think the claims would process, because UB04 is not set up for those line items like that. Would we just bill all of the codes that are now included under G0511 as on a 1500 fee for service? That seems the most straightforward thing to do, but I don't know how we work that relative to rural and non-rural health services. So whatever. There are a lot of questions about it. My point is the CMS proposed rule has a lot of meat in there and a lot of change for rural health and a lot of change specific to behavioral health as well. So all of what I just discussed with you is in the care management services fact sheet. I encourage you all to go take a look at that. The best way to get there is just use your Googler, but make sure you've got the 7.1, or excuse me, I looked at it 7.1. Make sure you've got the most recently updated document there. Brief word here on intensive outpatient therapy. What is it? These are services that are beyond what we would do in our clinic, but less than what we would do in an inpatient or residential setting, and less than someplace with 24-hour services. Provided for individual with acute mental illness. I have a crazy story about what's happening at my building right now that I'm sitting in with a gentleman who clearly is schizophrenic, but is also very dangerous, it seems. And he would, I'm sure, make use of some of these services, but IOP is distinct from partial hospitalization and less intensive than partial hospitalization programs. But like I said, requires a higher level of care than just isolated outpatient visits in the clinic. Individual or group therapy, furnishing drugs. I'm running out of time, so I'm going to spin through a lot of these things. Specifies various services that are eligible under the IOP benefit. I encourage you all to go check this out. Up until now, there's a certification. There's the various requirements. I said you all can go read those when you can't sleep some night. The claim, the service, worth $284. It's 3 separate services on a given day. And so far, RHCs were excluded from that benefit. We could not bill anything as rural health clinic encounter. It's a basket code, just like that G0511. So all of these codes would be, any of these services would constitute an IOP service. Right now, our RHC encounters are not eligible. Cost reporting impact. This is what I'm trying to get to. Another final rule, proposed rule update down here, look at the bottom. CMS acknowledged, hey, you left us out of this, and now proposing allow us to bill for any of those basket services. We could bill per day, per IOP day, depending on the, I don't know what that means, depending on the service provided. So there's an IOP fix in the works as well. And between the G0511 and this one, those will go through, but definitely go make comments on what you hope to see out of behavioral health changes, and particularly that primary care definition. That's the final rule from last year that gave us mental health counselors and licensed and MFTs, marriage and family therapists. This is the proposed rule. You see it's linked there. I'll send these slides to Melissa, and you're free to go use them. And otherwise, those are my standard resources. So that's me. Hopefully most of you know how to get a hold of me anyway. And like I said, I'll make sure that the Burrows team has these slides.
Perfect.
So
okay, Charles, thank you so much. I will get your slides from you, and we will be sharing that to the team. I know we've hit the end. There were a couple questions that came in.
Okay.
So the big topic, you know, is the behavioral health 49% or primary care 51%, that whole ratio there. What is the exact total that it should be? Is it per provider that we look at that, or are we looking at as a whole total across all providers?
They're looking as a, trying to find my, here we go, total across all providers. It's in the state operations manual that they will measure it based on total provider hours available to see RHC patients. And it's, the specialty can't exceed, so anything outside of family practice, peds, OB, and internal medicine. Right now, that's primary care. Family practice, OB, peds, internal medicine. So a cardiologist would be a specialist and included in the 49%. Behavioral health providers are included in the 49%. All behavioral health providers. It doesn't matter that they're approved providers. You know, you get an ENT coming through, that's specialty service. You get a general surgeon coming through. I have always, and we always encourage rural health clinics to include specialists in their rural health clinic and not try to carve it out, but it does count against you on this 49%. Now, most of the time, those visiting specialists, they're not visiting enough, and we have enough providers that it doesn't make a difference. But when you add now our new behavioral health providers in, and we start doing a bunch of counseling visits, yeah, it absolutely could make a difference. So it's 49% provider hour, total provider hours available to see patients. We're going to compare the two groups of specialties that I just mentioned. Now, here's the thing. If there's, for some reason, they can't compare provider hours, I don't know what reason, but we can think of a myriad of reasons if the clinic just doesn't have the information. Let's start looking at diagnosis codes. They can look at anything they want to. Oh, well, you don't have a policy to tell me what is behavioral health or not. So let's just start counting patient diagnosis codes and which diagnosis codes are behavioral health and which not. Well, okay, anxiety and depression are always two of our most frequently used diagnosis codes. Suboxone clinic, let's say you're cranking through your Suboxone patients like that, you know, then you got problems. So it's 51% primary care, total provider hours available to see patients. And that's also why you need a policy. So you can define the providers and define their services.
Okay, perfect. I
that-
think that the second question was in relation to that, but you're answering it spot on. Is basically what is the best practice to monitor the behavioral health services versus the primary care services? Should it be broke down by CPT, diagnosis? But I think we're hearing you say defining our behavioral health policy.
And the technically that would be by provider hours. How do we measure it? It would be by provider hours. And you just stack them up next to one another and say, yeah, our LCSW and our cardiologist are here 18 hours, and they generally would look at it on a weekly basis.
Perfect.
It's generally how they would look at that.
Okay. Let's see. I'm gonna double check one more time in my email, make sure I didn't get anything sent separate. No, I think that is it. That is it, Charles. I
Great.
thank you very much. And I
Thank
still
you.
see some of the other speakers on the line, and I appreciate your time today in presenting for us.
We'll see you soon, Elizabeth. Thank you very much.
Thank you. Thank you, everybody. We'll be sharing
Thanks,
this soon.
Melissa.
Yes, thank you.